Thank you, Dan. Tom. Disclosures. So I guess you could classify them as things that may be devices or stents, and we could think about getting around, through or out devices. And for stents, getting through them either through the through lumen or the cell, maybe enlarging them by unzipping or molding them. So getting around devices. This is a patient with an ASD, pulmonary hypertension. I think has an Oclatec device. And you can see the amount of right atrial distension on intracardiac echo. And this patient really had anasarca from right heart failure, and we wanted to create a fenestration. So in this case, used intracardiac echo to guide needle puncture, but behind or underneath the device. And you can see what it looks like on fluoro, where we're actually, we're actually tenting up the device. We thought maybe we'd have to go through the device, but we were able to go underneath it. And then you can see with the needle across with an injection to prove that you're in the left atrium. You can see how big the right atrium is, the intracardiac echo probe over there. And then this stent that we've just seen, where you can see we have this diabolo stent conformation and using partial sheath inflation, and you have a pacing wire or a proline suture around it to create this diabolo conformation. And then you have your access and your right to left shunt, to relieve the heart failure from the pulmonary hypertension. And you can see on intracardiac echo the right to left shunt. So getting through devices. This patient has residual antegrade pulmonary artery flow after a Fontan operation, and there's hemolysis going on for years. And we already, and you can see it's, this was maybe more than 10 years ago, and you can see we already have a collection of devices, a 17mm Rashkin, an 11mm Amplatz septal occluder, and a 10mm muscular VSD device. And we've such amount of complex mesh metal there that it really is a difficult thing to treat. And the best way turns out to be to go through it with, you get your Terumo wire through it, a Rosen type guide wire, and then a long balloon. And we saw this technique earlier. I think this is Chuck's idea, where essentially you use this long dilator balloon, and then by deflating it, you're able to get a braided sheath through the area. And then to sandwich the whole area with a 35mm PFO device, which actually got rid of this patient's hemolysis after many years. You can see this patient also has per-atrial and per-ventricular pacing leads. And that flow went completely. Getting out devices, well, we're all pretty much familiar with snaring out the screw, but this is a patient with a 1412 Amplatz ductal occluder 1 device that has migrated through a ruptured sinus of Valsalva aneurysm after an enormous Valsalva maneuver when the anesthetist was waking up the patient. The patient actually gave himself a hernia at the same time. But anyway, we had the device back up in the right pulmonary artery, and for the life of us, we couldn't turn it around to try and grab the screw. I think we saw some of this in, Carlos Pedra's posters yesterday, where you're using a guide wire to go through the device. And then, in this case, we started with a coronary balloon to see could we just catch a little bit of the mesh and then pull the device out, or at least flip it over. At least this gets a move on the device. And then catch it. We then changed tack and caught the distal end of the coronary wire with a snare and pulled the device out. We thought it was probably reasonable at this point to actually take it through the heart, through the tricuspid, because we didn't think we had enough strength in the coronary wire to be able to pull the device into that area. It was still really hard to get into this recessed screw, despite using different sorts of sheaths, different sorts of snares, and coming from the opposite groin. So we grabbed the device around the middle, and then took it out through a 14 French sheath in the groin. And this is because it's short, it's really quite a strong sheath. And then put a muscular VSD device, which we sort of really wanted to put in the beginning. Moving on to stents, getting through a stent cell. We've seen cases yesterday with Christopher Petit going through the side of stents. We're doing more and more of these. This is a patient with a Sano. There's significant desaturation, and certainly the flow to the left pulmonary artery or both is severely restricted. So stent into the left pulmonary artery with a formula 14, that makes the flow to the right pulmonary artery worse. And then keeping one wire in and then going with a shaped wire into the right. And because it's open cell, you can dilate it safely enough and establish flow into both areas, and then the patient had a Glenn later on. This is one Damien Kenny gave me with this telescope technique, and this is a case that Ziad did as well, using Eunice's technique of lengthening down a stent, where mostly you want to avoid overhang of stents into pulmonary arteries, but here you actually want to do it, so you provide a landing zone for a valve and can put in a Melody valve and avoid a reoperation for this patient. But I think you do need a word of caution with side branch or going through the sides of cells. Here you have a lot of side branch overlap in a patient, about 10 years after stenting for severe hemoptysis and pulmonary with multiple peripheral pulmonary artery branch stenosis. And you can see there's very little flow into the right lower lobe area there. It's a closed cell. These were Yomed stents, and this is a closed cell structure stent, and going through and simultaneous inflation. You can see the tight waist on this. And there unfortunately we got a concentric balloon rupture there. And it really didn't want to come out. You were really stuck in there with a trapped distal balloon fragment. And this is one of these cases where you sort of want to use Shack's technique, which is to sort of cut off at the groin and run. But actually, we did persist, and then we actually cut off the back of the balloon. Then you're able to bring a sheath up the guide wire assembly so that you can apply force at the area where the actual balloon is trapped, rather than pulling from the groin and having just curves straightening out in the heart. And then bring up a snare through that over the shaft of the balloon. So that you can get the force at the right area, and you've got the sheath stabilizing things. And then by pulling, you do eventually come free from this area. And here eventually it gives. But you can see when you get this sort of umbrella type rupture in the balloon, where you get an umbrella forming distally. So we're able to get it out there. The stent isn't going to come, and there we're free. And then you need to finish off with the dilation, but maybe more cautiously to get it open. And you've got some flow into there. It's not ideal, but there's a limit with the cells you have. Obviously, the unzipping of these small diameter stents, you can see this very nice paper with the movie provided, and you've got a whole row of zigs unzipped, and a very important concept that you need to go graded. You've got to go up by a couple of millimeters with these fibroid balloons, whereas if you go up straight away, you actually strengthen the stent because you turn it into a wedding ring. And this is a patient who had pulmonary atresia VSD with a neonatal unifocalization, and then we put stents on ECLS to get out of trouble, and then the surgeon has been back with a redo conduit and incision of the pulmonary artery stents. You can see this stent over on the right has been incised. There's distal stenoses there as well, but this stent is only partially incised. And you can see using a high-pressure balloon to enlarge the area. You can see that going up there, and you're tearing a number of zigs. But I think there's a limited number of these cases, and ultimately, it's relatively ugly looking after you've unzipped that stent, and we stabilize it with another stent. But I think we will learn, as we do more unzipping, what the potential problems are likely to be, and it may be that we have to stabilize them with stents beforehand. So to conclude, mesh devices can be got through, around, or out. Obviously, use adult-sized stents and only implant undersized stents if unavoidable, and redo surgery likely anyway. I still think there's a relatively small experience with unzipping, and stepwise high-pressure fibered balloons is probably what's required. Proximal protrusion jailing best avoided unless you actually want to do it deliberately to allow telescoping. And I think you have to be a little cautious with side hole dilation use high-pressure fiber-coated balloons if possible. Thank you very much.